Good morning, good afternoon, good evening for everybody around the world that is connected with us to IFFS for this seminar. My name is Luca Gianaroli. I am the coordinator, the global coordinator for educational activities of the International Federation of Fertility Societies, and we are now connected as part of a series of pills that is one of our way to disseminate informations regarding progesterones. These pills, this is the second pill of the topic, and today we will have we will concentrate, thanks to Professor Dominic Stock, to a very interesting area on new progesterone role in human reproduction that is related to the preconception and the conceptional area of reproduction. Only a few words regarding Professor Dominic Stock. I'm pretty sure that many of you know him. He went through the medical school and the recognition in gynecology and obstetrics in Ghent University, where after a period of 10 years when he worked in Brussels, he is now back as a full professor in obstetrics and gynecology. So I think that we will be delighted to listen from him these novelties regarding the use of progesterone. And I would really ask everybody that has any questions to put the question in writing in a question and answer box. So at the end of the presentation of Dominique, we will have a discussion, and we can also have a live discussion if there is some topic that is really extremely, let's say, debatable. Otherwise, we will work on question and answer. So once again, thank you for everybody for having joined us, but especially thanks to Dominique, because without him, this presentation could not exist. So Dominique, the microphone and the computers and the videos are all yours.
Thank you very much, Luca. I'd also like to start with thanking IFSS for giving me this opportunity to talk to you and to discuss, hopefully afterwards, on this very interesting topic of progesterone. So, new progesterone role in human reproduction. Just trying to move, next slide to conflict of interests. So progesterone, if you look at the natural menstrual cycle, it's clear to see what phase of the cycle we're talking about. So progesterone is the hormone of the luteal phase. So this is something we'll talk about most of this talk, but it's also quite interesting that more and more we get interested in how progesterone can be applied and used in the follicular phase. This is the second part of my talk. And finally, I will also discuss how progesterone actually also plays a role in ovulation and where we also could explore opportunities for the progesterone hormone in our daily clinical practice as a method for ovulation triggering. So let us first have a look at the conventional role of progesterone in the luteal phase. What is progestin doing? Progestin is doing a whole lot of things. It works on implantation in many different ways. The most obvious one is a transformation of the endometrium to a secretory endometrium, so which is basically ready for implantation. So this causes basically the receptivity and is really crucial for the embryo to implant. But much more and many more complex things are actually happening at the same time. There's actually a whole modulation of the maternal immune system and inflammatory response which is taking place because of progesterone at the same time, and this has everything to do also with the fact that half of the embryo is genetically foreign to the mother's body. Another factor which is quite important and has also been studied a lot is the role of progesterone as having an effect on the contractility of the uterus. So the uterine contractility has been linked to progesterone concentrations in the serum. It also has been linked to chances of implantation and pregnancy loss. So these things are all linked to that single same hormone, progesterone. Now, let's have a look at what we do in our daily practice. So we use progesterone, all of us, in many indications, but all in the luteal phase. And most of us, and this is data from a survey, do it with vaginal progesterone. Vaginal progesterone is still, especially in Europe, the most popular application for progesterone to our patients, although other countries, especially like the US, IM progesterone is being used, but we also are using sometimes oral progesterone, and also more and more we start to use progesterone in combinations, where we're using different routes of progesterone for our patients in order to optimize the required progesterone for implantation. Now, we have been going through changes over time in the way how we do IVF, and one of them, the key changes, all thanks to more awareness of risks of ovarian hyperstimulation, and also because of the better cryopreservation methods we have thanks to vitrification, is the sharp increase of freeze-all cycles. So this means that more and more of our babies or more of our embryos are being transferred in cryocycles and no longer in fresh cycles. So more and more people are also focusing their research in how to optimize these cryocycles, because if we want to continue to increase the outcome for our patients, we need to focus there. And if you look at that, we need to look at progesterone. And that's what people have been doing. And so there's a plethora of studies where people have linked progesterone and especially serum progesterone levels to the outcome of these cryocycles. And as you can see, most of them are retrospective. Many of them are with rather small sample sizes. Most of them are done with vaginal progesterone. And most of them also surprisingly find or identify some kind of cutoff under which outcome seems to be poorer and above which outcome seems to be better in terms of ongoing pregnancy rates and in terms of miscarriage risks. So these are our findings that we've been confronted with in the last couple of years, and of course is something which is quite intriguing to us because we weren't expecting serum progesterone to relate to that outcome, while we are thinking progesterone is actually acting in the uterus. But nevertheless, it's a fact that we've seen in many publications. And another striking thing is their variability with regard to the number of our patients that are being affected by these progesterone cutoffs. Some studies actually mention up to 85% of population in that particular study to be with too low progesterone, or not at least the ideal progesterone concentrations. There's a wide variation. That is also quite intriguing. How could this be? And lots of this has to do with the small sample sizes of the studies in which the population is cut in 4 groups, in quartiles or in centiles and deciles, and then randomly cutoffs are being created. So this makes many, many different cutoffs. And lots of questions about to real clinical guidance and precise cutoffs. And that's what I would like to discuss and go look into further in this talk. Now, what does explain that many of our patients have different serum progesterone concentrations? So if we measure them on the day of embryo transfer or the day before, as some do. First of all is the pharmacokinetics, as we have with any drug, as with any hormone. And as women get older, with age, resorption gets better, thinner mucosa, and basically they do better in terms of serum progesterone concentration. The opposite we see with increasing weight, as in any other drug, as body weight increases, bigger distribution volume, lower progesterone levels. And a third one has been shown in this paper here is a history of low progesterone. Of course, they're more likely to have low progesterone measurements in subsequent cycles. As weight is related, BMI is also related, obviously. So this study, this is with IM progesterone. So women who are obese tend to have lower progesterone levels in their serum as women with normal weight or women with overweight, so without obesity. Another variable which is quite important for those of us who are measuring progesterone in the clinic is knowing that progesterone will, of course, decrease with time after administration, and also may have a circadian rhythm during the day. So depending on when your patients are being administered their progesterone, and depending on the time where you do your transfer, you may, and the time where you do your blood sampling, you may have different values. So we in our clinic, we had patients having progesterone vaginally in the morning and the evening, twice 400 milligrams, or some had 3 times a day, 200, 200, 200. If you do your transfer the same afternoon, same time, you will have different measurements. You will probably have different cutoffs. So this is important to realize. Another one is estradiol. We know estradiol induces progesterone receptors, signals to intravenous stimulation. That's why we need to give luteal phase support. The more estradiol, the more progesterone is needed. Now, from the data from Labarta, we've seen in proliferative phase patients with low progesterone on the day of transfer had lower proliferative phase estradiol. And if we talk about the luteal phase, there did not seems to be an association between the day of progesterone concentration and estradiol concentration. But what was seen in another paper was that ratio seems to be important. So those with a high ratio, meaning with high estrogen versus low progesterone, have lower pregnancy rates. So this is, in a way, a relation that has been seen. Sexual intercourse also plays a role. I mean, now in our center doing a study where people record their sexual activities in the 5 days before blastocyst transfer in order to see how this affects the progesterone levels. And as you could, of course, assume with vaginal progesterone, sexual intercourse will remove some of the progesterone, lowering serum progesterone concentration. While if you can check the husband, the partner, then progesterone in his body, of course, tends to go up because basically he's taken that away from his partner. So this is another unexpected variable. This brings us, of course, to the question, what can we do about it? So if we see that some of our patients, certain percentage, we don't know exactly how many are too low in progesterone, can we rescue them? Can we, at the day of transfer, give something more in order to give them the same chances as those with a progesterone value above the threshold? I'll go over some of them. For instance, the administration of IM progesterone could be an option in addition to already IM progesterone protocol, which is tested by Brady. Cutoff here was 20 nanograms per ml, which is higher than the classical 10 nanograms per ml, which has been seen in vaginal progesterone administration, but I come back to that. But here it's a higher threshold. People were given more IM progesterone, but that study did not see any difference in the outcome by increasing IM progesterone for those with a low progesterone level. So that doesn't seem to be efficient. Giving IM progesterone on top of PV, vaginal progesterone treated cycle, also did not seem to have the effect that they wanted. So it was 80 milligrams twice a day, vaginal progesterone, adding IM progesterone every 3rd day, no difference. Pregnancy rates were exactly the same. Now, a strategy which has been more successful in uptake among clinics is the one where subcutaneous progesterone is being administered. Most of this is derived from studies from Elena Labarta, from the EVRMA group, where patients, and this is a cutoff that she identified in her patient population, 9.2 nanograms per ml, who were given vaginal progesterone 4 milligrams twice a day. These patients were given subcutaneous progesterone from day 4 in case they had progesterone levels under the threshold she identified. And then pregnancy rates were the same. Of course, this was not a randomized controlled trials and could be criticized for that. But of course, there's historical data she had from her same clinic, similar population, and then corrected for all potential confounding variables. And then looking back before these additional injections, pregnancy rates were significantly lower. So in a way, she suggested a solution for those with a too low progesterone levels purely based on vaginal progesterone. Now, the question that comes up is, why don't we give all our patients much more progesterone? We give as maximum we can vaginally, we can give injections. And if everybody has the maximum amount of progesterone, then there will be very few with suboptimal concentration. But then the question comes up, could too much progesterone also be deleterious, or could it lower pregnancy rates as well? If we go to the IM progesterone, data is conflicting. So one study shows like a continuous increase, a linear increase with outcome if progesterone levels increase. All the studies seem to show that it starts to decrease from a certain progesterone levels onward. You see this here, this blue line seems to go down. Missed abortion, biochemical pregnancy rates goes down. Also live birth rates tend to go down above a certain threshold. So this is conflicting. So what about vaginal progesterone? Is there something that plays? But first, before going there, I think it's also very important to know what the difference is between the vaginally administered progesterone and the one that's been administered through injections. We want our progesterone in the uterus because, like I said, there's secretory transformation, uterine contractility, and so forth, the immunological response. If we look at serum progesterone, we see that the serum progesterone increases much slower when it's given vaginally. So this is the blue one, the blue part on the left side. While giving an injection, it tends to increase much faster. The complete opposite is what we see if we go into the uterus. Vaginal progesterone increases much higher and much faster progesterone levels in the uterus, in the endometrium, as compared to the intramuscular progesterone. So they have a complete different pattern of distribution in the body and location in the body, of course. Now we need to be aware of the fact that we measure it in the serum. So if we measure it in the serum, then of course subcutaneous administration will quickly give a high level in the serum, but at the same time, in the uterus and the endometrium, progesterone levels may be low. And the opposite could be said from the vaginal administration. So this, of course, has a huge impact on these cutoffs that we look at. Now, if you look at the vaginal administration and you look at several studies, and I put here 3 studies that have been published in the last couple of years, you tend to see on first sight from a distance that is kind of bell-shaped effect of progesterone levels. So we see that the more progesterone they get in all 3 studies, the higher the pregnancy rates, but then there seems to be like a peak and then it seems to go down. Now, the 2 important remarks, the first one is that only 1 out of these 3 studies, it seems to be significant. So this, the paper by Jovic and RBM Online, so the significant reduction in chances for those with a higher progesterone level. So in the 2 other studies, this was not significant. So basically does not exist. It's just something we assumed visually, but it's not there. Sample size may be too low. But on the other hand, what we also notice is that the progesterone levels in each of these bell-shaped curves are totally different. And so there's no consistency at what progesterone level it would go down or whether there would be too much. So I think from these data, we can't make up whether too much progesterone vaginally given would be harmful. Another thing that's important is that the progesterone being administered in the Jovic trial, where there was significance, was progesterone that was self-produced. It was not like the commercially available progesterone as has been used in the 2 other trials from Labarta and from Alsberg. Another study that was indicating that progesterone could be too high comes from the study from Alsberg. It's from the group from Peter Vermeiden from Denmark, where they have a quite innovative way to find a new route to administer progesterone to our patients, and it is a rectal way. So these patients were given both vaginal progesterone and rectal progesterone, and the cutoff was 8.8 nanogram per ml as to define people with too low progesterone. And the first note from this study was basically that discomfort from the rectal progesterone, which you could assume to be higher than vaginal, was not the case. So basically, on the 7-week scan, actually significantly fewer patients complaining of discomfort with the rectal administration as compared to the vaginal administration. The second thing that they've seen is that there appears to be a maximum cutoff. So there's 14.50 nanograms per ml cutoff, which is the 45 nanomolar per liter. People above tend to have, and it was significant, just 0.04 lower ongoing pregnancy rates with these rectal progesterone. So here it shows actually too much progesterone could be harmful. And so shown in one study with IM, as I've shown, and the Jovic study with vaginal progesterone. So all three of them, there are indications that too much could be harmful. Now, going to another study, which is quite interesting, is a very recent one from Milo. Milo also, who wrote a meta-analysis showing that 10 nanogram per ml could be the cutoff. Of course, it was based on not that many trials, but another trial which he performed later, he came up with a different cutoff. So there was a study with a very heterogeneous group of patients with natural cycles, frozen embryo transfer patients with HRT. It's 402 women were included in the study, and the lower cutoff was 7.8. So again, is a confirmation that this cutoff levels vary a lot, and it is so far one of the lowest cutoffs we've seen. So they tend to range from 7.8 to 10. And again, this was decided by the centiles. So it's not a statistical cutoff, it's just basically randomly the lower 10% of the population that appears to be statistically significant. A second thing that he's seen, and I think this may be the most important finding from this study, is that there was a reduction in the mean probability of live birth in patients who were exclusively treated with subcutaneous progesterone. So here the cutoff level was 16.3. Remember, with the rectal, it was 14 nanograms per ml, above which lower pregnancy rates were seen. Here with subcutaneous progesterone, 16 nanogram per ml as the cutoff, above which lower pregnancies were seen. You also looked at the risk of miscarriages. That did not seem to be significant, depending on progesterone levels. But there was a trend, as you can see here in the figure on the right, to higher miscarriages. But again, it was not statistical significant. So basically, we can't comment on this. This is also very interesting, comes from that same paper, where you can see, depending on the route at which you provide the progesterone to your patient in these frozen embryo transfer cycles, where you can see different ways progesterone concentrations in the serum relate to outcome. You see here in green is the natural progesterone, and then basically you see the more progesterone, the better. Yeah? If you look at the micronized vaginal progesterone, more or less you see the same. The more progesterone you give to your patient, or the more, at least I should put it better, the more progesterone you measure in the blood, the better the outcome seems to be. And then, as what I just mentioned, the subcutaneous only patients without any vaginal progesterone, there seems to be a cutoff. And you see it's really bell-shaped. Those with progesterone above 16.3 nanogram ml, you seem to have lower pregnancy rates. So there could be a risk in just giving the subcutaneous progesterone. For those with combined, and this could be any combinations, it was like a flat line. I don't know if you conclude much of that, because it's a very heterogeneous group of patients and treatments. Now, going to the fresh embryo transfer cycle. So fresh embryo transfer cycles, not that many studies have been performed, much less as in cryocycles. Progesterone also tends to be much lower, much higher in fresh embryo transfer cycles, because we had this ovarian stimulation, we had many more estrogen, much more corporal lutea after the egg retrievals. So there's a much higher endogenous progesterone production, at least in the beginning. And then, of course, you need to supplement the luteal phase. And all what we consume, of course, is that the cutoffs will be different. And because of the higher estrogens, more progesterone will be needed to bind to all receptors. Study from Thompson, also from the group of Peter Humayden, also found here in the patients where the early luteal phase progesterone was measured, a significance also with too much progesterone was harmful. Going back to the rescue strategies, we discussed rescue strategies with IM progesterone, with subcutaneous progesterone. Could we also rescue our cycle with giving more vaginal progesterone? Cédrin Durnerin from France has done a study. So she took the cutoff at 10 nanograms per ml, and patients were treated with 600 milligrams utrogestan a day, so 3 times 200 morning, lunchtime, evening. And then she increased the progesterone to 1200 milligrams a day for those where that arbitrary set cutoff of 10 nanograms per ml was not reached. And then almost 70% of these patients the next 2 days later, actually reached the 10 nanograms per ml. So basically, that goal was reached. And then looking at pregnancy rates, you saw 20% pregnant in those above 10, 12 those below. This was not significant. Of course, sample size was way too small to find any difference here. Another study by Volosky, which was originally presented as a retrospective cohort study, was quite interesting. And there was a letter written in response to that publication by Alsberg and other people, colleagues in the field, to comment on this paper. And in this study, people were given vaginal progesterone, and basically the study was just aimed to find a threshold. But it was retrospective, so there's always prone to bias. In that study, it was written in the discussion part, some patients were given additional vaginal progesterone, and that was not standardized. It was based on the discretion of the treating clinician that he or she could give additional progesterone, and the cutoff there was 8 nanogram per ml. What they've seen in this study, which was basically interventional study, is that the threshold was come down from 10 or 8 or whatever we've seen before, 9.2 to 5 nanograms per ml. So basically, by modifying the amount of vaginal progesterone, by basically increasing it, the threshold has gone down. And this, of course, has huge clinical effect because the number of patients with suboptimal progesterone levels decreased a lot, and because the percentage of patients under 5 nanogram per ml is significantly lower as percentage under 30. Under 30, it's about 30%. Under 5, it's less than 5% of patients have less than 5 nanogram per ml. I come back to that in the next slide. So basically, partial supplementation has a huge effect on determining the cutoff. And this is also confirmed from our own data. This is now under review. What we've done, we looked in our clinic retrospective to over 1,000 cycles of artificially prepared cycles, so frozen embryo transfer cycles. So they were all given vaginal micronized progesterone, 800 milligrams a day, 400 morning, 400 in the evening, and we only supplemented the cycles with 5 nanogram per ml or less. And so all those above were not given any additional progesterone, either vaginally or subcutaneously. And what we've seen is that progesterone did not seem to relate with outcome. So this basically seemed that in our experience, the cutoff must be below 5 nanogram per ml, but was above, we saw no effect. And the consequence also was that only 3.9% of our patients needed to be supplemented with subcutaneous progesterone, which of course has a huge effect on our population, and also not only on the convenience of having fewer injections, and because you go from 30% to just under 4%, but also on the cost of the treatment. So what you can see on the right is the receiver operating curve. So after this policy of under 5 only subcutaneous progesterone, we no longer see any progesterone level where we could define a cutoff of lower outcome. Now, almost coming to the end to this part about the follicular, the luteal phase. And this is a very interesting study by Elena Labarta, also to have a better idea of how progesterone works. And so she was basically looking at the 3 pillars of progesterone. She looked at progesterone in the blood, progesterone in the endometrium and metabolites as well. And she looked at a marker for endometrial receptivity with which she used the ERA test. And so gene expression in the endometrium, and looked how they related. The first thing that was interesting, but was already known from previous studies, is that the serum progesterone does not relate to the tissue progesterone. And this is quite intriguing because we're always focusing on that progesterone in the blood, while studies repeatedly show that what we measure in blood doesn't say anything about the concentration in the uterus. So this also need to make us think about the pathways and where that progesterone in the blood is actually making a difference on implantation and on maintenance of pregnancy, which is probably going to be immunological. The second thing is the relation between serum progesterone and the receptivity. So it's just assessed by the error test. There did not seem to be a relationship. So basically, the serum, whatever progesterone you have in the blood, does not relate to whatever's happening in the uterus. Same thing as the previous thing has shown. The only correlation they've seen is that there's a correlation with what progesterone is giving, is available in the uterus, and what is the endometrial gene expression is doing, as something, of course, which we already knew. So in order to conclude, there's a direct effect in the uterus, directly enhancing embryo implantation. There's an indirect effect, and this is more systemic immunomodulation, not only during implantation, but also later in pregnancy. You have a potentially effect on preeclampsia and on preterm birth and so forth. Which is also interesting, and that also puts it into question with regard to the importance of progesterone in the uterus, is that actually studies have shown that very little progesterone is needed to have a secretory transformation in the uterus. Only 5 milligrams a day is necessary to have that transformation. Above that, doesn't matter, it's all changing. But of course, gene expression will continuously change with increasing progesterone, but just having the secretory transformation requires very little progesterone in the uterus. So I come back to that. Indirect effect is the systemic immunomodulation of pregnancy, has been shown in many studies. Then finally, how about the natural cycle? Many studies have been done, and some are contradicting. This is data from the group from Politis from Dexeus. They looked in PGTA cycles and non-PGTA cycles. Of course, PGTA cycles having higher implantation, but above all, both of these cycles, with or without PGTA, they were related to how much progesterone was measured in the blood on day of embryo transfer. So basically, this does not mean just going away from artificial cycles to the natural cycle will solve your progesterone problem. You will still need to supplement with progesterone. And that's also what's been confirmed now this year in Fertile Sterile. In the meta-analysis, they're looking at frozen embryo transfer cycles, natural cycles, with or without progesterone supplementation. Live birth rate significantly higher with progesterone luteal phase in natural cycles. Clinical pregnancy rates, of course, as well. And miscarriage rates, it's not significant, but you see the diamond is on the left side of the forest plot. It's on the side that favors progesterone. So this brings us to progesterone during ovarian stimulation. So it moves us from the second to the first part of our cycle. First, a word about late follicular progesterone rise is something we're all very much familiar with, and it is based on this beautiful paper, impactful paper from Kolibionakis from already over 20 years ago, where he has shown that an endometrium that is advanced because of ovarian stimulation for more than 3 days will no longer be able to receive or to have an embryo implanted. And so receptivity is lost. And so progesterone is the hormone of the luteal phase, shouldn't be too abundant in the follicular phase. That's quite clear. The same thing here, and that has its clinical implications. The 1.5 nanogram per ml threshold, nicely shown by this iconic graph by Ernesto Bosch, above 1.5 late follicular phase, day of triggering, lower pregnancy rates. So then freeze all. Now, but not going to detail the late follicular phase, right? Because we have the easy solution of the freeze all. There's another way that progesterone has a new important role in the follicular phase, and this has everything to do with the high exogenous progesterone effect. We can administer our patients with exogenous progesterone in the follicular phase during ovarian stimulation. And what does it do? You can see it here on the lower right side. It will prevent the LH surge. And this is because of the effect of progesterone on the GnRH pulse frequency. If the pulse frequency goes up, as you can see above on the slide, you will have LH FSH surge, you will have ovulation, If it's stable, nothing will happen. So this is basically the PPOS. This is the progestin or progesterone, which you could use as well. So this is not only progestins, the synthetic ones, progestin primed ovarian stimulation. Nicely described in this paper by Borisata, where you can see where from day one, you start stimulation, you also start with progesterone. Progesterone every day, it's a pill, that's much cheaper. It's not painful as an injection of a GnRH antagonist, and also so much cheaper for the patients. Of course, it's only be possible in the freeze-all cycles. But as I said, freeze-all cycles become for most of us the main thing we do. There are several progestins and also micronized progestin that has been tested. They all have the different doses in order that are needed to inhibit ovulation. And there's also, as you can see, a flexible PPOS protocol where you, as an analog with the GnRH antagonist, start on day 6, or you could make it also flexible based on follicular size. So you have a shorter time of progesterone administration. Meta-analysis have already been performed comparing the outcome, because that's what counts, is how many eggs do we have, because it's freeze-all. Don't care about implantation. Number of oocytes is actually the same, or let's say it's not different. So same number of oocytes. Looking at pregnancy rates, of course, it will be from the cryocycle because it's PPOS. No difference. A live birth rate per woman, live birth rate per embryo transfer, no significance. And if you see the diamond is on the side of the PPOS, it's not on the side of the GnRH antagonists. And also for different patient populations, it's all feasible. If you're looking at the diminished ovarian reserve, or the poor responders, as we call them, and normal ovarian responders, PCOS high responders, it works for all. So it's effective for all, and pregnancy rates are equal for all. So this is very easy thing to do. And this is an abstract which I want to share with you, has been presented at ESHRE, Copenhagen last summer. And in that study, they compared flexible GnRH antagonist protocol versus PPOS. And that study, 20 milligrams of micronized progesterone was given. It was a prospective study. And we were going 2 cycles, one with PPOS, one with GnRH antagonist. We saw a significantly higher number of estradiol, LH, progesterone, of course, progesterone, and also more oocytes, more mature oocytes, and more zygotes, so more fertilized oocytes. But the number of blastocysts, euploid is the same. Of course, it would be quite spectacular to find a difference here with only 44 patients. Also, Antonio Lamarca has looked at this. This was done with progestin, not with progesterone. Same percentage. He found the same thing. And then also the flexible one I mentioned before. You start on day 6. Same thing, no difference. Of course, it was a small study, retrospective study, but I know of centers, large centers, using these flexible protocols as we speak. So I'm pretty sure bigger data sets will come out confirming the deficiency of the late start PPOS, and so on day 6 start, or depending on follicular size. And then finally, we're coming to a close. A word on progesterone for ovulation triggering. And it's a bit contradictory because we've just been talking about progesterone to prevent LH surge and to prevent ovulation, but there we talked about high dose progesterone, especially for the progestins because they're very potent. But if you look at the normal cycle, the non-stimulated cycle, we see that prior to the LH surge, we see, of course, the estradiol increase of the growing follicle. We also see a small increase in progesterone, a small increase of endogenous progesterone, probably leaking from the maturing follicle. And that progesterone comes in circulation, and some way, potentially, it may also have its role in signaling to the pituitary, hey, I'm ready to ovulate. Just let the LH go. Yeah? So it makes a lot of sense. Yeah? There's been a couple of years ago a nice commentary for Till Strill on this potential use of progesterone to trigger ovulation. And this paper also came out in JARC this year, where people were triggered with progesterone for ovulation. They were given IM progesterone, 5 or 10 milligrams progesterone intramuscularly, and led to ovulation just by giving progesterone. So I think this, of course, needs to be further explored and to see what this does to the endometrial receptivity, because, of course, if you give the progesterone 48 hours before ovulation, you have this premature secretory transformation that could, of course, lower implantation. So, but potentially, as in nature, if it's done in a very small amount, just enough to trigger ovulation, but not enough to change the receptivity, it could be something that we may be using more in the clinic in the future. So this brings me to my take-home messages before I invite you all to join in the discussion. First of all, progesterone, as you know, I don't think this is a no-brainer, has a crucial role throughout the whole of the pregnancy, basically from the second the embryo gets into the uterus for implantation until the baby is born. On every step, every day, it has its role in many different ways. The serum progesterone around the day of transfer seems to relate with treatment outcome. I think we can't deny this because all these studies seem to show some kind of relation, but that relation still is not very well understood because we can't draw uniform conclusions, in my opinion. Yeah? So there are conflicting data with regard to the cutoff. Of course, population studies are different. They go from 5 nanogram per ml, which is what I see in my clinic, my experience, up to people putting 10 nanogram per ml forward, and could be very well that somewhere in between. Potentially maximum cutoff could there be too, and the important one to notice is that subcutaneous progesterone alone actually had this cutoff 16, the same we've seen for the rectal one was 14 nanogram per ml. Progesterone has a unique role to play during the follicular phase. So the PPOS protocol is getting more and more popular, especially for colleagues in Asia. Quite impressed how often it's used there. And preliminary data about progesterone as an ovulation trigger are there too, but of course, they need to be much more further explored. So I thank you for your attention, and I will stop sharing my screen now.
Yeah.
I think I just did. Yeah. Okay.
Yeah. Thank you very much, Dominic. Very comprehensive, very useful, and very well presented set of data. I think that there are many points that I'm pretty sure should be discussed. I encourage our audience, if there is any question or any doubt, to put them down in question and answer, allowing everybody to mention this. I see that somebody is nicely using the chat instead of question and answer, but it doesn't matter. We are also able to manage that. So the first one comes from a colleague that is most probably based not in Europe. And the question is, do you have any comment on using oral dihydroprogesterone to rescue low progesterone levels?
That's a good question. There's data on this. I didn't include it in my presentation, but the clinic I used to work, the people from Brussels, Shari Marcus, has published in RBM Online, I think a year ago, their policy. So they give dihydrogesterone 3 times a day, 3 times 10 milligrams, so 30 in total, for those patients with a progesterone level measured in the serum under 10. It was a study done in the same way as Labarta has done with subcutaneous, but instead of the subcutaneous, they were given these 30 milligrams, and they also did no longer see any negative effect of having progesterone under 10. So it's true, it's also an alternative. It's a very good question.
Thank you very much, Dominique. I hope that our colleague is satisfied of is satisfied of the answer.
I
And
hope.
while we are
Yeah.
while we are waiting Sorry, Dominic, do you want to say something
No,
else?
no, 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 no. Just go on. I was just listening.
Yeah.
Yeah.
Okay. No, I'm saying that while we are waiting for other questions, I was wondering if you can discuss a little bit more about how much is too much, because you show data that an abnormal increase of progesterone could be deleterious. But I'm not only wondering about the pregnancy rate. I'm wondering about the impact that a large amount of progesterone could have on unphysiological situations of the placenta. So, in other words, are we sure that using this, let's say, iatrogenic activity of progesterone at very, very high level could not be in one way or another related to some of our complications in during pregnancy? I'm referring, of course, to preeclampsia. I'm referring to other disorders like placenta creta and so on. Do you
It,
have
it,
any?
it's a very good question. It's of course potentially related with the fact that some data say that the natural cycle with natural estrogen, natural progesterone, and also, of course, also relaxin and other molecules coming from the corpus luteum seems to give safer pregnancies. But at the same time, also data coming out that if you supplement pregnancies with progesterone, you tend to have lower preeclampsia. So it's a bit contradicting. So it doesn't seem to be that the progesterone is the one causing the preeclampsia. I don't think so, because otherwise giving additional progesterone wouldn't lower it. The fact with the natural cycle is basically it's other factors. It's the relaxin, other factors that actually making it safer. So I don't see, as far as I see the literature, that progesterone in any study had actually shown to be a risk factor for pregnancy, and actually most to the contrary. It's increasing, reducing the risk of preterm birth. It's lowering the risk of preeclampsia. So I don't think, but of course, the thing is we need to gather the data. We need to have precise registration of all these complications, link that to the use of the medication in order to find that. And then again, to find a cutoff as to when is too much, it's going to be quite difficult, even in our very well described and very well monitored stage where we're in, and fertility clinics, where you just look to the first 7 weeks, it's already a hell to find the cutoffs with such a heterogeneous patient populations. How is this going to be if we're going to look to the big wild world of all pregnant women where we have no idea what they're taking? But anyway, it could be, but I think as to now, I don't see in the literature any clear risk that progesterone could be causing that risk for placenta problems. But it's a good question. It could be something we need to explore further.
Yeah, because in one
Yeah,
way or
yeah, yeah,
another,
yeah,
it is a little bit contradictory related to nature, because we know that
yeah.
after the 7 week, the placenta should take over. So there should be no need of extra progesterone in physiological pregnancies,
Yes,
while we are using extensively this
it's very.
drug in all the patients.
It's true. That's true. That is. But the thing is, maybe nature needs a little hand. So that meta-analysis I showed about these cryotransfers in natural cycles have also shown that there's better outcome in natural cycles with additional progesterone. So
Mhm.
it also shows that basically nature isn't that perfect. Maybe very arrogant to say that because there may be something we're missing here, but seems to help for them. Just looking at live birth. Of course, we don't know
Yeah,
how to get to live birth, but yeah, but
yeah,
it's a good
yeah.
question.
Okay.
Yeah,
Yeah. We also have another question that's stand for in natural cycle, I would suppose it would be in natural cycle, is it possible that progesterone supplement actually downregulate endogenous progesterone production?
that's probably the case. That's probably the case. That this feedback will work. It's the same thing what we're doing with the PPOS. So we give them progesterone in order to shut it all down up there. But of course, if we give enough progesterone, that will not have any negative effects. But that's true. Yeah? So it could be if you give supplementation but not enough, that you make things worse, that you stop the endogenous, but you don't supplement enough to take over. It's a very good question.
There is a comment by Paul Piet that I think that all of us know as a proj expert. Says, indeed, a recent MA by Pedro Melo suggests that exogenous P4 decreases the rate of PE in natural pregnancies.
That's what I was referring
And
to.
that is what you, yeah.
Yes, yes, yes.
So he wanted to
Yeah.
be sure that the message went through.
I think so. He wanted to give the real name for people who want to look it up. It's Peter Mel. Yes,
Exactly.
yeah, yeah.
And do you have any comment on using well, this I've already gone through. And then we have from Peter Stein. Do you propose any change in the specific gonadotropin used during PVOS protocol, specifically relating to basal level of endogenous LH being abnormally low? Should we routinely monitor LH levels on some specific day of stimulation in order to decide or choose the gonadotropins?
It's also a very good question because it shows of knowledge of the endocrinology, and is something that also struck me when I was looking at these first luteal phase stimulation cycles. You looked at the duostim, also from Italy, from Ubaldi's group, and also going back to Kuang in Shanghai. They all give either HPHMG with LH activity, or they gave the Pergoveris with both FSH, REC-LH. So many in the beginning started to ask, yeah, you probably need to give that with that LH, but that seemed to work. Head-to-head comparison with or without LH effect is, to my knowledge, not been done. So we can't answer, but what I can tell from my own experience and also from a few studies, there have been studies more recently with pure REC-FSH without LH activity, giving good outcome. But it could be for a small proportion of patients that additional LH could make a difference. So measuring that, I don't know if that will help, because then again we need to find thresholds, and this is going to be difficult. And we know, of course, LH is necessary, but very little LH is necessary, and it's also in our routine follicular phase stimulation. We also assume that some may need additional LH, but also there we haven't clearly defined those who actually benefit from it, apart from those who are hypo. But from the others, we don't know either. But I think it would be nice to do a head-to-head comparison with that, and also would be interesting to look at the triggering effect, because we do the GP, we call the GP the gonapeptyl triggering. It could be anything. It
Yeah,
could be any the agonist triggering, to see whether that's equally efficient, where you gave the REC-FSH or you give LH effect, or of the suppression, and also in relating to the type of progesterone given, whether you give progestin or you give the natural micronized progesterone, which also tend to lower LH less, enough not to have ovulation, but still needs to be LH to get your patient triggered. All very
yeah,
interesting things that need to be answered in the future.
yeah. I mean, going
Yeah,
back to the
yeah,
Jurassic time of IVF,
yeah, yeah,
this year, 23, is the 40 years in which the first paper with Anna Pia Ferraretti and Georgiana Seeger-Jones was published 40 years ago in fertility and
yeah,
sterility, where without any analogs or antagonists, because they didn't exist at that time,
yeah,
they were measuring during the follicular phase of stimulation for IVF the small pulses of LH. And what they noted is that if the pulse of LH is not mirrored by a small pulse, let's say increase of progesterone,
mm,
the ovocytes were at that time called mature and normal. While if this small pulse of LH were
mm,
also having increase of progesterone during the follicular phase, again, the eggs were looking more, let's say, post-mature. And at that time, the
yeah,
follicles were punctured by laparoscopy. So you could also
yeah,
see the amount of bleed that there was in
yeah,
each follicle. And
yeah,
there was an increased amount of course, luteinized follicles. So that's again It was done 40 years ago, but
Yes.
it's interesting because now we are getting exactly the real proof
Mm.
scientifically in a better way that that is the way to go.
Yes.
Um, yeah, it's interesting. There is another
Yeah.
question. Is in clomiphene citrate and when to start progesterone after ACG? After how many days?
The question is, I remember Professor Paul de Vroy talking about this at the time. So the clomiphene citrate tends to increase your LH and still tends to increase
Yeah,
endogenous progesterone reduction, and whether you would then need additional luteal phase support. It's very
or
clear if you give FSH stimulation, even in IOI and with high estrogens, it's of course quite obvious to do so. But with clomiphene citrate, as far as I know, there's no evidence for need for that.
yeah,
Yeah,
yeah. There
yeah,
was
yeah,
a paper in Fertility and Sterility by
yeah, yeah,
Paul. Yeah,
mm,
yeah, when
yeah,
he was
yeah,
working with us in Italy.
yeah. Mm.
Yeah, good. Do we have other questions for Dominique? I think it's a unique opportunity that we have him here still for a few minutes. So here we have another question that is related to um,
NPP.
that is from an anonymous.
Yeah.
So
Mm.
so could be anybody, but he's anonymous.
Yeah.
Please comment on the role of progesterone on NPP
Frozen embryo
PET
transfer. Yes.
cycles. Yeah,
Yeah.
so that means frozen cycles. And maybe do you want also to say to explain the NPP? Maybe
I
somebody
think
of us.
I think it's progesterone primed. I think
Yeah,
that's something that's now been also it also was an Eschweiler last summer. And I remember it's some of the Santos Ribeiro. It has some nice data presented there. Um,
could be natural progesterone prime.
yes, I think so. It's a natural cycle, started off natural, and then
Yeah,
there are cutoffs. So basically, it natural cycles, which then in theory are the ideal ones, but they are so difficult in your clinic to use because then you have your transfers in the weekend, and of course you want your weekend free, especially if you're a small clinic. I don't have the continuity. Artificial cycles have that advantage, but there's like a hybrid form, which is called an NPP. So basically, the patient starts off with a natural cycle. Um, we here in our clinic, we let them come the first time at day 11 if they are regular. And if they have an endometrium of 7 millimeters, if they have an estradiol 120, 140 or more, and if they have a dominant follicle, like 13, 14, then we start progesterone. That's also what he has done. It's still not published as far as I know, but it was an abstract at ESHRE. And then 5 days later, or 5.5 days, because you start progesterone in the evening, and the 5 full day of progesterone, morning, evening, vaginal progesterone, embryo transfer is done. And then you continue, of course, your progesterone supplementation. And then, of course, you have the scheduling advantage. So since we do this, we don't have any transfers in our weekends or holidays, bank holidays, because of this approach, and still we have our own patients ovulating. So which what I talked about, these relaxin and other factors that could be important for reducing risk of preeclampsia, are still there. So you have the best of two worlds. You still luteal phase support, and you have your scheduling and your corpus luteum. So I think it's something that will become more popular in the future.
Okay, we
Yeah,
have
yeah,
one more question
yeah.
from the colleague Al-Kazemi. The question is, after an LH surge, when is better to start progesterone for luteal support?
That's a very good question because we had this discussion last week on our medical staff. Um, because you could have two views. If you would ask Human Fatimi, who is very much fond of the natural onset of the progesterone rise, then you would tend to wait a bit. You give the patient time for natural progesterone to increase, to build up, and only supplement maybe 1 or 2 days after that. So just to supplement to keep progesterone high, but let the transformation rate and intensity be the natural one. What we tend to do in our NPP cycles, so when we see an LH rise, when that patient first come, we start progesterone just the next the same evening. We start, so we just basically take over, and we still set the timing so that we CLH today. Tonight we start progesterone the 5th day we plan. So we don't let the same natural rise come, but we just take over. Just basically the answer is just you can start your progesterone straight away, and then you have the NPP cycle. If you would not want NPP and want to have normal ovulation, you could just wait 2 days and then start progesterone on the day that you normally would ovulate. I hope that
Okay,
answers the question.
Yeah, Dr. Said is
Yeah.
asking what range of progesterone is safe to transfer frozen embryo and in which day to measure it.
That's a good question, and I was hoping to answer this with this presentation, but I couldn't because the answer isn't, in my opinion, not out there yet. So the progesterone that is safe, in our experience, we take from 5 nanogram per ml or higher, which is 96% of our patients, they have enough progesterone with vaginal progesterone. It's only 3.9% of our patients who are under 5, and then we supplement.
Sorry,
Yeah.
sorry, when this value has been picked up, or in which day?
So we measure on the day of transfer. So patients go for embryo
But
transfer, and then we do egg retrieval, and then if we adjust, we do it from the next day, the day after
okay,
embryo transfer.
but
Yes, yeah.
for blastocyst or day plus 3?
For blastocysts, we only do
For
blastocysts.
blastocyst,
Yes,
okay.
yes.
It's important our
Yeah,
audience know. So we talk
yes.
about blastocyst,
For
and we are
blastocysts,
talking
yes,
about making
yeah,
the blood sample the day before
yes.
or
And
the
I think
same.
this, yes, some do the day before. I
Mhm.
personally don't see any difference. I also don't see any difference in thresholds presented based on the day before the day itself. And it's a good point you make. Look with that day 3, because as far as I know, all papers on this are done on for blastocyst cycles. So for day
Yeah,
3, it could be still totally different.
yeah, correct.
Yeah,
Yes, but since many
yeah,
people
yeah,
are anyway using day plus 3 transfer, so I think that we should be aware of this.
yes,
Yeah,
that's true.
very good. I'm looking around, but I don't see any other question, and I think that our audience was very interested since you received so many questions. If there are, oh yes, there is another one. That could be one of the last one, and is again from the same colleague. If we transfer on day 3, and that's what we were talking about
Yeah.
before, what is the range? Here we are.
Yeah, we don't know. We don't know what, at
Yeah,
least I don't know. I need to speak for myself. There may be people out there who know it, maybe have it in their own clinic, determined, haven't published it. But from published literature, I can't say what the ideal
yeah,
range is. Um, of course, what you could do is transfer on day 3 and have your patient come back 2 days later to measure it on day 5, and then use the day 5 thresholds, which are already available. I think this is probably the easiest way to do, unless you want to set up your own study on day 3 and make your thresholds for yourself. But the meta-analysis by Milo is on day 5 transfer.
yeah.
Yeah.
Very good. So I think that we have really finished our time.
Yes.
But let me
Mm,
only say
mm, mm.
to think. One is, first of all, of course, to thank you, Dominique, because it was extremely interesting, your presentation, and you have a glimpse of this if you think about the questions that have been posed to you. And I would also like to thank Basins for helping IFFS in organizing these activities. I like to say that this is a completely, fully unrestricted grant in which IFFS is choosing independently the speakers, the coordinators, the titles of the pills. So these are activities that are fully educational activities, but we should not forget that without the help of our not only speakers but also our sponsor. And without the help of industries, these things cannot be dispatched all around the world for free. So once again, thank you to Dominique, thank you to Basins, and I hope that those of you that are interested in progesterone will follow also the other pills that are in the same pipeline. And you anyway can take the opportunity to have a look to the website of IFFS where all the educational activities are listed and where you can approach us whenever you like. So once again, Dominic, thank you very much for your time, for your presentation.
You're welcome. Thank you very much.
And
Bye-bye,
thank you
everybody.
everybody to
Yep.
have been with us from all around the world, from what I understand. That's very good.
Bye.
Okay. Bye now.
Yep.
Bye, Dominic. Thank you very
Bye.
much.
Bye.
Bye, everybody.